Good evening, everybody. Thank you for joining me to talk about how to elevate your implant dentistry with digital technology. My name is Heath Brantley, and I'll be going over a couple case studies that I am currently involved with. I have been using the Celea dental laser for almost 7 years now, uh, maybe a little over 7 years. I've been training for a little over 6 years. It has definitely kind of infected my practice, if you will. I was not a laser dentist before investing in an all tissue laser, so I kind of jumped in with both feet. And I really loved kind of the restorative outcomes that I get, the efficiency gains. And so I've kind of turned into a laser dentist, I guess, if you will. I'm also heavily invested in CEREC technology. I mill and produce almost all of my own restorations and guides in office. I like to teach a lot of digital dentistry, and I'm also a full-time practicing dentist in Wendell, North Carolina. The first thing I want to kind of introduce to everyone, of course, I'm not sure what everybody's level of expertise is with lasers, but if you're like me, when I heard laser 7, 8 years ago, I always assumed they were just soft tissue. They were ways to kind of manage the gingival tissue when I'm prepping a crown. And really, that was kind of the box that I put lasers into. Well, of course, I got introduced to an all tissue laser and really started to dream about what can be done with it. And the word all tissue certainly does mean all tissue. Essentially, every tissue in the mouth that you encounter can be ablated with the Celea all tissue laser, which is the one I happen to have. You can do crown lengthening procedures where you go between removing the gum, removing the bone, removing the caries, prepping the tooth that you're doing the crown on. You can be as tissue selective as you would like to be. It all depends on what you set your settings at or how hard you push on the foot pedal, which we'll get into in a minute. But really, when you think about a general dentist, they're encountering pretty much every problem in the mouth. Most of us are in the trenches. We're treating everything. We encounter all kinds of dental materials, all kind of clinical challenges, whether it's surgical challenges or restorative challenges. We kind of see it all. And this all tissue laser is really something that's kind of changed my practice because in a lot of ways it's replaced a scalpel and it's replaced a drill in a large number of circumstances. So a few key points that I would like to talk on, because again, I learned this myself over the last 7 years. A lot of us, we always assume we're being as efficient as possible. I don't think anybody's trying to waste anybody's time when we're at work. But one thing I noticed was like my efficiency went up dramatically when I cut out the no anesthesia part for majority of these procedures you're going to see today. And also when the bleeding is no longer causing me to leave the room because I can't really work in a bloody field. So I was leaving the room and having my dental assistant kind of manage it. And that was really kind of bloating the appointment. The patient really didn't need to be there that long if you could control bleeding. The next thing is just patient experience. I know we're all trying to provide a better experience for our patients. And when you do that, you can't help but get more new patients coming through the door. So this has definitely been a product that has helped me with new patient flow. I didn't need more new patients. I was very happy with where I was at, but when you continually give better results than patients are expecting, they tend to refer people to you. Another thing with the all tissue laser, again, I got it. I don't know how much you know about Celea, but one of their main things is anesthesia-free fillings, and of course, that's why I bought it originally. I have since then, um, moved on to actually like doing different dentistry. Like I'm doing a lot more soft tissue surgery, a lot more bony surgery. And I, of course, had no idea that I would be doing that when I bought the laser initially. And then also, I mean, you guys, I know you want to have minimally invasive dentistry, you want to have better healing. So the laser is a tool that will allow you to do that. So, what makes it unique? We have to go through at least one I want to take out like one, I guess, chemistry lab graph here. So absorption curves. The main reason that this laser works is because the 9.3 micron laser, that wavelength of photon light energy moving throughout space, is being absorbed specifically by hydroxyapatite. Uh, and it's where hydroxyapatite absorbs the most energy. So when, like, the analogy I like to use, there's a lot of different lasers that are out there. They all are absorbed in hydroxyapatite or water or some combination of the two. But when you're absorbing something 100 times faster than a another laser is, you can't help but be kind of faster, and your settings are going to be manipulated to to basically make that as efficient as possible. So we'll kind of get into that in a minute. Here we go. The next kind of graph is just has to do with how deep the laser is penetrating into the soft tissues. As dentists, we are almost exclusively dealing with capillaries, which are very small, of course, and the diameters are tiny. And when the laser can penetrate to the depth of the capillary, it squeezes the capillary off and causes it to not bleed as much. Of course, you still get a little bit of blood here and there. It's very clinically dependent. Somebody with very terrible gingivitis or periodontitis, they're always going to bleed no matter what you're doing to them. But the main thing I want to point out here is that this is not a cautery tool. There are lasers on the market that produce a lot of heat, almost like an electrosurge, and they will cauterize tissue so they can get pretty much any bleeding field to stop, like a traumatic field to stop. But we're talking more about like the pristine health of a patient. Like they've got minimal gingivitis, they've got healthy tissues, and you're just trying to not induce bleeding. So one key thing is we are not cauterizing with this laser like some other lasers are. So one other unique feature of this laser, before we get into the clinical cases, is the variable foot speed pedal is very important. It makes it more natural is the best way to explain it. I know that other laser brands out there, the soft tissue ones that I've demoed in the past, you have to change your settings and turn your machine on and off constantly, and you're either too high or too low. You're cutting too fast, you're cutting too slow, and every time you have to start and stop what you're doing. But with a foot pedal, you just push harder to cut harder. You let off the foot pedal to have more control, and have smaller cuts, if you will. The other thing is the software drives all the changes that happen with this laser. So when you update a software pattern, you all of a sudden have a totally different laser. It either blades faster, it doesn't ablate at all, it becomes subablative, which we'll talk about that maybe later on. But you saw the simulation on the left there while it was playing. The computer is controlling those dots. You are not moving your hand at all. You're just holding the laser still. And the pattern that you saw dancing before you, pulsing at 900 hertz, that was entirely the computer driven system. And of course, that foot pedal is very important. So for you guys, I'm going to show you just kind of the general dental visit appointment. I've talked through a couple of these cases in the past, like the average class 5 lesion for somebody that's been out of school practicing for over 5 years or more. That's probably going to be 25 to 40 minutes of chair time. Not because the dentist necessarily needs that, but the dentist is only in the room 10 minutes of that whole appointment, but the patient is taking up space because you've got to wait to calm them down. You've got to inject them. You've got to control bleeding at some point if it's a bad subgingival class 5, and all that adds up. Like your dental assistant is attending to them that whole 25, 40 minutes, even if you're off somewhere else. In the Salea visit, it's generally much faster because you cut out the blood. That's the main thing. You just control the soft tissue very well. But the other thing is you don't have to really necessarily wait for numbing. You just sit down on virtually every class 5 and just get to work. So I have a couple zoomed in videos just to show how the laser can interact with soft tissue, and you'll see later how that kind of applies to implants. This is a standard class 5 where you don't really know where the lesion is. Like you see that it's there, but how far does it extend apically? Well, my preference is to remove the gum nowadays and fully visualize the lesion, have a nice outline form, and then once I can establish healthy tooth structure around the whole lesion, then I just go for the middle. So this is about a 30-second prep, as you see, and the soft tissue was absolutely not a problem at all. Soft tissue only starts to bleed after you're doing your finishing, and you nick the gingiva a few times with your finishing burr. Another video just to kind of show the all tissue purposes that are going on here. You've got an enamel lesion here. So this one's not necessarily down on the root this time. You're cutting the enamel away. Again, same technique, trying to get an outline form. So you started coronal this time. I like to, just kind of use my spoon to get that out. I don't know why that's so satisfying, but it is. And again, this patient's not, they're not numb. You're just kind of getting a feel for, is this big decay? Is it chunky, or is it kind of just a couple tenths of a millimeter deep? That's the main thing I'm checking for when I use an explorer or a spoon in that situation. And then we're going to remove the decay, again, letting off of the foot pedal because decay is softer than enamel is. And you can see how you just paint it away. Really just trying to give you a general understanding of what all tissue means. Like you can selectively remove caries if you want, or you can remove harder enamel. You can bevel enamel if you want. And then, of course, we're re-angled here. The caries is almost completely gone, but the gingiva is right over our margin. So you can, same setting as caries, just kind of roll over the tooth and give yourself a little restorative room without inducing any kind of bleeding. So with that being said, you guys kind of see how it interacts with normal general dentistry type situations. We're going to get into kind of the implant content now. This first case is an annoying case. I honestly didn't really encounter situations in my career where the abutments had come loose. I just hadn't done enough of them, I guess, yet. But when I can't imagine getting this case in my office where I don't have a laser to kind of deal with this. So like the patient comes in, their abutment has been gone for a few days or weeks or months. The soft tissue's completely collapsed and grown into the fixture itself. That's a difficult situation. I've never had to face this not having a laser, specifically Celea. But here you go. So you have this and you're trying to help the patient. You're probably trying to maybe reuse the implant crown or abutment that loosened up. And as you can see, you set your settings on your laser and you selectively remove just the soft tissue from inside the implant and anything that's kind of around it. You can even increase your emergence profile to help with the seating of the crown because it's probably going to blanch when you go to put it back in. And again, just this is an everyday headache at a lot of heavy implant offices where there's not really a good solution to this unless you have some kind of all tissue laser that can selectively remove the soft tissue without heating that metal down there. All right. So you guys, I'm not sure of the audience and who might be listening, but in general, a lot of people who are looking at something like an all tissue laser, they oftentimes are already doing same day dentistry. They're invested in CEREC or some other digital scanner, and their goal is to make the patient's life easier. They're trying to get same day scans done. They're trying to get crowns to seat in the fewest amount of appointments possible. And the laser is certainly an adjunctive tool to what you're already doing with your digital scanners. So here's an example of just, patient who had an implant placed, whether, I place my own implants, but Every now and then I get an implant from a surgeon that's buried and or they're relocated and I have to uncover the implant. That's obviously not that big of a deal when you have a laser. Um, but first step is to apply topical. Almost always place topical in these cases. The better you get with the laser and managing patient expectations, you can get away with not using topical, but it's so easy to apply it. I just go ahead and do it almost always. And so you want to obviously locate the center of the implant first to the best of your ability. There's a lot of different ways to do that. I oftentimes have a guide, so I just point down the middle of the guide and hit it bullseye every time. But once you uncover it, you go ahead and place your scanning abutment on there, and then you can place a healer if you want. I oftentimes go ahead and make the same day screw retain crown depending on how well the implant is placed. So, if you're going to see the patient back in a couple days or a couple weeks, then go ahead and place your healing abutment. But if you're going to deliver it, just leave it exposed like it is. You can always hit it with the laser again in an hour if the tissue collapses a little more, and go ahead and place your implant. So we're going to get into uncovering an implant, and we can see like this is a very pristine site. Very easy to impress, very easy to place a healing abutment versus, what does this look like? This looks like a 1 week post-op where there's a flap made. There was maybe stitches, maybe not placed, but the tissue's super inflamed. It's very uncomfortable to go back into that site. You could probably go back in and place your crown a week later, but the patient's going to be very uncomfortable when they have that much inflammation on board. So that's kind of the more traditional look. 3 weeks later, it's not perfect. This is probably more where you would intervene and get in there and go back in for the second stage and put your crown in after uncovering it, but the tissue doesn't look happy. So again, we just compare the two. There's immediate post-op versus a 3-week healing, and the immediate post-op looks amazing. So we're going to show a video uncovering an implant. This is more of like a freehand approach, if you will. We're obviously assuming the implant is in the middle of the two teeth, which is not always the case. And the key to these types of procedures is really you're just easing onto the foot pedal at 20% power. Really just trying to let the tissue talk to you. Like, is it removing a little bit too fast for your comfort level? Do you feel like you can control the contours of the emergence profile? If you feel like it's a little bit jagged, you're normally cutting too fast or your hand is moving too fast. But I mean, again, this is real-time video. It takes 15, 20 seconds to even visualize the implant, and then you can spend as much time as you want contouring. But this is, in my mind, a lot more predictable than cutting this with the scalpel blade and getting bleeding and then having to place a healing abutment and coming back and placing a crown later. So we're going to focus more on this emergence profile concept. So a lot of us receive these back from the surgeons if we don't place our own implants. And of course, it's a circular, emergence profile, and we may want something more oval. And of course, with the Solea, we can do that. We can make it as oval as we want. We can make it triangular. We can make it square. We can make it whatever shape we want. We just, do what feels best to us, or maybe we wait and see what the lab sends us back from an impression potentially. If you took your impression really early on in the process, like I'll show you in a later case, you may get something that's a little over contoured from the lab and it blanches when you go to seat. That's a little bit of a trial and error. You wait to see where it blanches each time you seat it, and then you remove selectively from whichever corner of the tooth is blanching. So we've got another situation where like temporary crown comes off. We've got all this cement on there to remove. Soft tissues collapsing on the abutment. I oftentimes try to reuse the same abutment on the same person. And just being able to clean that abutment up super efficiently is, used to be a challenge. For sure, I'd have to remove it. I'd do something in the lab to try to get all the cement off. And then, of course, the tissue is just going to collapse when you take everything out. And if you don't have a healing abutment to replace this abutment while you're doing all of that, it really can be a headache. It's much easier, in my opinion, just to leave it the way it is. Don't take anything out of the mouth. Just take your laser to it, expose the margins. Oftentimes, you could even scan this abutment the way it is in the mouth, and mill a crown to cement back onto that. That's especially helpful if you don't know exactly what implant system that you're trying to repair or replace. So we've got another case here where we've just kind of sculpted the tissue subtly so that we can get some temporary crowns on and then wait for healing. So we're going to get into kind of a little more advanced concepts now. That's all focused on soft tissue primarily, where, we're either uncovering an implant or we're trying to improve the contour of the emergence profile when you remove a stock healing abutment. But now we're going to get into how can we maybe apply this to our implant practice on the hard tissue side of things. So, of course, being digital dentists that we are, we have CEREC technology, we have CT technology, we have Celea, we have a lot of different toys. We always plan everything crown down, of course, and we want to integrate our Sidexis program to do that. And you can see here where the implant has been placed under the crown, which is the best place for it. And then we're going to try to simulate what we're doing here. So you see kind of this cartoon where you've got a guide that is sitting on the teeth and is got a tube in the middle of it where you put your key, and you're going to shoot down at the red soft tissue and ablate that away because that's, in the way of the bone. And ultimately, we need to make an osteotomy. So this is one particular technique where we shoot through the guide. We kind of mark the tissue. We burned it, if you will. And you can see that it's like a whitish gray look, depending on, how hot it got. But that's our marker that's where our implant is going. So now we can remove the guide because it is very difficult to work through the guide. Okay. I think my video didn't play. All right, we're going to move past that. I'm sorry about that, but that was supposed to be a video to show kind of removing the gingival tissue after the guide was removed. So here we've got healing abutment that we took out. It's a stock healer, of course. We're looking at all the keratinized tissue, but it's circular and it's kind of narrow. We want it to be a little bit wider. And so what we're going to do with our laser is we are going to gently increase the diameter. Let's call it a millimeter around the whole implant. So if you add a millimeter on both the buccal and the lingual, that's increasing the diameter of the circle 2 millimeters total. And it just makes for a more gentle, subtle emergence profile. This can be as fast as you want it to be, or it can be as slow as you want it to be. It all has to do with control. I like to tell people that when you're using a laser like this, it's like driving a car. What I think might be comfortable, like speed limit wise, going around a curve might be different than what you think is comfortable. And so I might drive 50 miles an hour around a curve. You might drive 60, and that's okay. We still get to the same place. You just do it the most comfortable way possible. So, this patient's anesthesia free. We're just, again, increasing the diameter of this circle. This is a fairly round space, it's maybe a slightly oval. This is going to allow for us to take a same-day scan where we can take an image of what that Pontic looking space, emergence profile space looks like so that we can mill a crown that fits intimately. And like we mentioned before, you can obviously do this retroactively as well. A lab may just send you a perfectly idealized emergence, and you can just try to seat it. And when it won't seat, you can then do this. It's a little bit more of a guessing game, obviously, when you do it that way. But um, this would be my preference, is to go ahead and do it before you capture your impression. Very minimal bleeding. It looks a little red and irritated in there, but it's not bleeding all over the place. So we're going to place our scan post in the CEREC world. That's what we call it. And then we're going to image that and place a crown a few days later. We'll go ahead and fast forward a little bit. Well, actually, I'll go back because that's kind of an interesting thing. If you're going to place this crown on a different day, which we are in this situation, you take your stock healer and you add a little bit of composite, about 1 millimeter around the whole thing. And then you screw that in to maintain those contours you just spent so much time creating. So the point here being, if you see the patient back in 2 days to deliver a crown, all that work that you just did is going to collapse. But if you place this stock healer in there, or I'm sorry, this custom healer that you made, and of course there's ways to 3D print this nowadays, but this is more of an old school technique. So there we are, 2 days later. The tissue is nice and firm against that composite that we made. And then that's going to allow us to seat a crown with minimal blanching. And of course, this is most likely a general dentist that placed this implant because it goes right through the middle. I've had some complicated situations recently from my specialists, which I need to have conversations with them about, because it's put me in some very difficult, almost impossible restorative situations. But when you have a crown that's digitally planned and it goes right through the middle, it's a restorative slam dunk. So with that being said, we're going to get into some very, the only way to say it is experimental uses of the laser. I started looking into some research that's been done, and lasers have been used for decades to cut bone and do tiny osteotomies and place little pins and rats and various things, but there's not really a widespread application for that yet in modern practice. So I've been experimenting a little bit just in my own office, trying to do some places where I make like a little punch into the bone, make the initial 2 millimeter osteotomy with my laser, and I think I'm on to some ways that kind of give me better clinical results. So I was going to show those with you tonight. Call this first technique the pilot laser. What we're trying to simulate here is we've got an extracted tooth, and you see the angulation that we're trying to put the implant into, but we also have the socket of the tooth extraction. So when you drill into something that's at an angle, you guys know that you're going to hit the side of the alveolus and deflect. And what you end up with is not the angle that you planned. And, I know surgeons are well aware of this, and they place freehand, and they're very talented. But general dentists, we're under the assumption that, like, if we use a guide, that this is not happening. But this is definitely happening when you use a guide. And I've really struggled with immediate placements and have shied away from doing them in the past because of this very problem right here. I would rather let the bone heal completely for 3, 4, 5 months, and then go back into a pristine site and have less issues with the deflection. But I'll show you nowadays, this is kind of more what I'm doing. I'm bringing my laser in through a guide. I'm shooting a laser beam straight, and of course that laser beam does not deflect. And when it's done, I have a protocol for this. We don't have time to get into right now, but after a prescribed amount of time, turn the laser off and you have a little bit of a notch in the palatal section of the socket. And what that then allows for is you to put your drill into your guide, and then you don't get any deflection. So for me, this has been an absolute game changer as it relates to being able to do more predictable same day immediate placement implants, specifically in the anterior, but this technique applies in the posterior as well. So here's a patient. Main complaint is they've had to have number 9 re-cemented 4 times this past year. They moved to the area recently and they're finally ready to do something about it. So, of course, everything starts with good planning. Originally, I was trying to do this immediately, and I planned a 4.3 by 13 Nobel active implant. But the tooth was a little more difficult to get out than I had anticipated. So I actually ended up, instead of doing this, same day implant, I elected to take it out and graft. But you can see, like, again, it goes palatal, and you have to go at least 3 to 4 millimeters apical to the tooth to get into that native bone so that you can get any hope of stability. But like I said, this tooth was so difficult to extract that I did not feel comfortable putting an immediate implant into this one. This is the post-op. I mean, it doesn't look like I traumatized the soft tissue that much, which is good. The bone is a little more traumatized under there, but I wanted to maintain all the papilla that I could so that I could do a provisional. So this person was bone grafted, and we did a Maryland bridge and Emax. There are stitches in there. That's probably not needed. That's a little overly precautious. But there are stitches and a collar plug in there. But if your Pontic is really well made and fills in the space, I certainly have done these without any stitches or collagen before. But that's the same day post-op for her. And, this is, I like to joke, is the world's smallest retainer for a Maryland bridge, but her occlusion supported it. And this same Maryland bridge was used multiple times on her between steps, because the next step is to see her in 3 to 4 months to remove that Maryland bridge by wiggling it for 3 to 4 minutes and seeing a nice soft tissue space that we maintained. This is where a pilot laser technique comes into play again. We don't necessarily have a socket wall that we're dealing with, but we're shooting it through the guide, just a photo of what that looks like. It's a better photo of what that looks like because you can see the laser coming out on the other side and interacting with the soft tissue. And then once I have punched in past that cortical plate, or I feel like I'm just maybe 2 millimeters into the bone, that's when I like to engage my drill, because I can feel it not only going through the guide, but I can feel it indexing into the bone itself. And so that is a comforting feeling to me that I'm not getting the deflection that I'm kind of, used to getting when I use a guide and it hits a socket wall or it hits a different density of the bone and you feel it kind of move on you. So you've done the osteotomy with the 2.0 pilot, and we're judging our angulation. There's a lot of bone in this case, so I didn't necessarily need an X-ray. But I do like to put it in there, kind of look at it from a couple different angles and see what is going on. So after we enlarge the osteotomy with the burrs, we go ahead and place the implant through the guide. And this time it's a 4.3 by 10. We didn't need to go as long as we did last time. The head of the implant is at the exact same level that I planned it last time. It's just 3 millimeters shorter because I don't need to get into that apical native bone like I did if this was an immediate implant. So here we see same day scan post. So the implant torqued in, so I'm feeling pretty good about it. I put my CEREC scan post in there. I go ahead and do my scanning. and then we see her again in 3 to 4 months. And so we've removed the same temporary in this situation, that Maryland bridge. You see all that kind of excessive resin. I might have been a little sloppier the second time around. Um, but we got to remove that with our laser now. And of course, that gingival margin, that papilla is very red from all that resin that's been sitting there, that extra flash, but they will heal from that. So the implant is there. I like to try to do a little torque test on my implant. I put like the implant driver on there and I put like 15 millimeters of torque just to see if it'll spin. Because, if it spins at 15, there's no sense in putting in my crown because it's going to spin when I try to torque that down. So that everything was rock solid. So then I put in my split crown. For you guys that use CEREC, you're probably familiar with, you've got screw retained crowns, and then you've got crowns that you can split into a custom abutment, which is what this is. And then the cement retained crown that will glue on top of this. So this is kind of her final crown. We got pretty lucky. We got very, very close in shade on the first attempt on her. And again, this is a same day uncovery, anesthesia free, custom abutment we made on our CEREC from a scan that we took 4 months prior at the time of surgery, and then the EMAX crown that cements over the top. So that is one pilot laser example that we'll go over. So here's another example, this time number 8. This is a comprehensive patient who has a couple restorative needs. But her main concern was she wanted a second opinion because I guess she was getting mixed feelings on another clinician in town. And they were very much about to refer to 3 or 4 different locations to try to figure out how to sequence things for her. And she just really didn't have a lot of confidence. So she came in to see what we would say. I diagnosed her with root resorption and told her that, it's very hard to predict when that tooth is completely going to fail her. But, I like to have control over when the tooth comes out, not it randomly break one day and then we don't have all the information we need to give her another tooth on the spot. So we elected to actually do her implant treatment first in this situation before we got to some of her other restorative needs. So everything always starts with a CEREC scan. Obviously, we want to know what the tooth looked like before we ever got started. And then it also helps us with our future planning for that tooth. Same thing, Sidexis, Galileos. We bring in the stone model here and we try to plan the implant. And as you can see in this situation, it's not got as much room, but I was feeling like we could do an immediate on it. Keep in mind the drill. I have done this before where, you want to go just 5-10 degrees off where the apex of the tooth is pointing, but you're going to come right out the facial. And that's very, very unfortunate when that happens. So, I don't want that to happen. So I'm going to use my pilot laser to not have that happen. Here you see that the implant has been placed and we've put in, this is a Neodent implant. We've got a 2.5 tie base on there that we will later be using on her. But for right now, we're doing a same day implant impression with the OmniCam. And here's the scan. I like to talk about this main point right now that there are so many problems with implant depth that can be addressed if you do this one step. So take your implant, scan as soon as you place it, take 5 minutes to design a crown before you suture the patient up or place a healing abutment or cover screw. And you will see if your implant is at the right depth, or if specifically in this situation, I like the depth of my implant on this one, but I was in between tie base sizes. So I almost went a little bit smaller with my tie base, but in general, I think what I have was doable, and I went with it. So then I put my cover screw on in this situation, and I just buried the implant and made her an Essex retainer. So she's been wearing an Essex retainer for the last 3 months, and maybe we're a little bit over zealous with it, with that kind of pontic space. Um, but it's fine. We uncovered the implant with the same guide that we used to place the implant. So just minimally invasive there. I'm redoing my measurements here because I don't like to glue. You guys keep in mind, I'm making my implant crown ahead of time. So this patient is leaving from implant surgery, and I'm already milling their crown out. So when they come in, I don't want to glue it to the base because then it's stuck to the tie base. So I double check my measurements. Like, am I at least 3 millimeters underneath the soft tissue? Because I picked a 2.5 tie base for this case, and I don't want to be showing gingival margin. I don't want to strip my gingival margin to show the metal collar of the tie base. So then I placed the implant. We kind of overshot it a little bit. It's way overvalued here. It's a pretty looking crown, but it's just too light. And, based on where we had left that Essex retainer, the margin discrepancies there, but she had that same discrepancy before surgery. I will probably remake this crown at some point, but we're going to get through her other restorative work first, and come back to this crown once she's had it for several months, and we can discuss what she wants to change. I think obviously the color needs to come down in value a little bit, but if there's some contours we can change, we're going to discuss that before remaking it. And that brings me to my last case tonight. Right at the beginning of COVID, of course, April 2020, I had submitted an article that got published in CDocs, and it was talking about doing laser osteotomies. So, I took the laser pilot drill to a whole nother level. I thought, like, let's do the whole osteotomy. Don't use any like rotary instrumentation. I didn't even use a scalpel blade to make the flap. And so it got published in April 2020, which is a terrible time to publish anything. But, of course, I didn't know what was going to happen there. So the patient presents with just a failing bridge. The main concern is number 18 has caries, and it's got those pins, and I just don't know what's going to happen when I open that tooth up. She doesn't have number 15, so we're trying to move her to like a first molar kind of occlusion. She just has a very hard time with root decay and like maintaining those second molars. So we're moving her to first molar occlusion. Number 18 is going to be extracted at some point, but until then, we're going to use number 18 to be a distal abutment for our guide that we're going to make. This case, first step here is we section the bridge. The assistant, we had a little bit of a snafu with retraction there, so I did lacerate the patient's gums there, as you see on the right, but they healed from that. But when we do a incision on a case like this, I like to make it between those lingual line angles there, and then just pull all that full thickness flap to the buccal. That almost always is enough of a flap to see the bone level here, because I was doing it guided, but I was also just using a laser, so I wanted better visibility for the surgery. This is one of the random photos in the middle of the surgery. You can obviously see it's a laser. It's a little more erratic of a cut. It's not going to be perfectly cylindrical like a burr would be. There's a lot of measuring that takes place, like a lot. So, I'm measuring with a probe. I'm measuring with these fatter instruments. This particular tool is from Nobel. So I think that first mark on the bottom is 7 millimeters. So you can see that I've got a pretty reasonably wide osteotomy that's almost at 7 millimeters deep. One thing that I learned from using the laser, because I primarily used it to cut teeth. And so, teeth preps are anywhere from like 2 millimeters deep to maybe 5 or 6 millimeters deep. And I've never really had any issues. But when I started trying to cut past 7 to 8 millimeters deep with the laser, I started encountering like some slow cutting, and I attribute it to pooling in the prep. So you've got blood that's pooling in that osteotomy, and it becomes a little bit um, self-defeating because you're not really getting down to where the bone is. You're just ablating the blood before you get to the bone. So I took my guide out and I put the key into the bone, and just that distance between starting way up here, like 6 to 8 millimeters higher, and having it have to go through a tube and then hit the bone. That's why I kind of made the decision to put the key into the bone. My visibility got a little bit better. The next question I had was, well, how do I know the angle that this key is like in the bone? This is not a very sophisticated approach at this point. So what I did was I put one of my angulation pins into it and kind of like straightened it up to what looked right. And then I took the angulation pin out and used my laser to continue the osteotomy. Eventually, I was able to get to about 10 millimeters deep. And this turned into a oh wow moment. Like I have a fixture that's, you know, 10 millimeters long, and let's just try to drive this Nobel active into the implant site. So I did that and got great torque on it. The osteotomy wasn't necessarily the most uniform looking thing in the world, but this is an aggressive implant. It went right into place. It drives itself, so the angulation changed ever so slightly, but it was a recoverable thing. I think it was, I'm being critical, it's leaning distal a little bit, but I think the patient's going to be just fine. So there's the same day placement. It's subcrestal. We put our scan post on there like we always do, so that we can make this crown, assuming we have uneventful healing. And then the patient comes back, but I felt more comfortable doing the same incision again, just that lingual to lingual, basically incision, so that I could push all that keratinized tissue buccally and then place the implant. This patient actually came in. It's about almost 4-year-old case at this point. They were in a few months ago, and we took updated photos in hygiene. And this thing probes really well. The tissue looks nice and healthy, and there's been almost no bone loss, but there's issues with these short tie bases. So I'm very happy with kind of how this patient is doing, given that it's been 4 years. So uh, again, this is just kind of showing you my journey with the laser and implementing it into my implant practice. Some of this is not very practical right now, but it's getting there. I could see a point where we might have settings on our lasers or something like that, where we can literally tell it the height and width that we want something, and then we push a button and it does it. So this was all freehand. It was very experimental. It was proof of concept. I had a good time doing it. The patient got a good implant out of it. It's still in the mouth. It's got minimal bone loss. So, I think, lasers are a viable tool to do bony surgery with. So that being said, I think I can get into some questions and answers. Okay. So there's a little bit of a question about danger to implant threads. So like the fixture threads. This laser doesn't interact with metal itself. I mean, it's an irrigated laser, so there's a ton of moisture. There's 13 milliliters of mist per minute. So the metal's not overheating, and it's not ablating when the photons hit it. So, you don't see any damage. I've used this on all kinds of metal in the mouth, like cleaning old retainers that fall out of people's mouths. Uh, I've used it around braces to get flash and excessive composite away. It just doesn't really interact. Now it reflects off of metal, so you have to kind of be careful with your settings. I don't use high power on metal because I don't want it to bounce off and like hit my glove finger or something like that. But I haven't, it doesn't ablate metal. It reflects off of metal. So I've not seen any damage. I've not seen any studies that talk about overheating implants, unless you're talking about non-irrigated things. So if you're not using a cooling agent like water, then yes, you can heat up the metal. But most of the lasers on the market that I've seen, they use water to maintain their temperatures. Um, yeah, so the laser osteotomy is definitely not more efficient. I appreciate that question. This was the pilot laser is helpful for me because it guarantees great angulation. But that's just uh 10 to 20-second procedure. So you put your guide on and you do the little notching in the side of the socket like we were talking about. And then it's very comforting to me to be able to put my 2 millimeter pilot drill into that notch and verify the angulation before I ever stop drilling. So when I go to use my rotary instrumentation, I'm pretty sure that I'm not deflecting. So the pilot laser is helpful. Now, doing the whole osteotomy is not efficient. It's just proof of concept to show that it can be done. I think the technology's got to be improved some more. It can cut the bone. That's not the problem. It's more of a settings thing. We've got to be able to figure out how to cut 4 millimeter wide holes without doing it freehand. The laser I'm using is 1.5 millimeters wide. So I'm having to cut a 4 millimeter wide hole with a 1.5 millimeter tool. So there's a lot of freehand in there. But I hope I answered that question. Um, so with the lasers for refining prep margins, that's a good question. So I'm going to assume that's more tooth related margins. What I like to do is go around the tooth at 10 to 20% power because it's not really cutting the enamel at that power, especially if you're moving your hand pretty fast. What it's doing is it's kind of cutting out any weaker parts. So to me, it's like running a polisher over your margin. It's just very fine refining. Um, it's probably not that noticeable to the naked eye. If you got heavy magnification, you can probably see that like 4.5, 5.5 loops. You can see the difference. But if you're using your normal eyes or 2.5 loops, you probably aren't going to notice the difference with the definition of your margins. But yeah, it's all about the power. If you overdo the power, you're going to ditch your margins and you're not going to want to use the laser. But if you use it at the proper settings, it will improve your margins for sure. And at the very least, it will sanitize your prep, if you will. There's a lot of clinicians I know that the last thing that touches the tooth before they cement things or bond things is the laser. So they isolate, they sterilize the whole tooth surface with a low setting, and then they glue their restoration into place. And it definitely cuts down on post-op sensitivity because there's no bacteria being sealed in there with your cement. Right. Well, I've got another minute or so. If anybody has another question, I really appreciate you guys spending the evening with me. Soleil has been a fun toy for me, if you will. It's a nice instrument that complements the kind of dentistry I was already doing anyway. And so anytime I can kind of get some synergistic effects going on, like I really do, it just makes me more efficient. So I really appreciate you guys tuning in. I will see you guys later.